Hello, and welcome to the Atlantic's Health Equity Summit. I'm Candace Montgomery, Senior Vice President and General Manager of Atlantic Live. We are glad you are joining us today for this session produced by our underwriter, Bristol Squibb. Here to explore achieving health equity through voice and power of communities, please welcome Curtis Eskridge, barber and owner of Cut It Out Kurt, Susan Irandu, Director of Clinical Operations at Lupus Therapeutics, an affiliate of the Lupus Research Alliance, Melanie Narain Blackwell, health advocate, founder and president, Color of Crohn's and Chronic Illness, and Kareem Watson, Associate Director of Community Outreach and Engagement for the University of Illinois Cancer Center at UIC, with Patty Doikus, Executive Director of Health Equity at Bristol Myers Squibb.
Good morning, everyone. Thank you, Candace, and thanks to the Atlantic for so thoughtfully putting together this Health Equity Summit. Good morning, good afternoon, and good evening to all of you and to our panelists, especially to Francine Lazlier, who has stepped in for Novaline today. You have joined us for this panel, which has the title of Achieving Health Equity, the Voice and Power of Communities. And really the purpose of the panel is to share real-world examples of how to engage communities that are experiencing health disparities, both to advise and help design and inform interventions, and also to deliver those interventions as well. Sharing examples with our partners and our panelists here, they are partners of Bristol Myers Squibb and the Bristol Myers Squibb Foundation, and we're really honored to partner with them and certainly to be with all of them today. So I thought what we would start off today in this discussion is just to go around to each of our panelists and hear a couple things. One is standing in the shoes of their communities that they serve, standing in the shoes of underserved patients. What would health equity look like? So we often talk about what it doesn't look like. So I think it's important for us to step around to what it could look like and then begin to press forward in our efforts to reach that. So I'd love to hear from everyone. What does that look like? And then how are your organizations moving forward to achieve that vision that your communities hold? So we'll start with you, Susan.
Sure. So health equity and the lupus space, and this is just an idea of what it would look like from my perspective and my experiences. It looks like a space with multidisciplinary care, where patients are asked to be a part of their journey or describing their health plan, and where there's options. Right now in lupus, there aren't too many options for treatment, and there's too many misdiagnosed or underdiagnosed cases because oftentimes people who have lupus symptoms do not always get to go to a rheumatologist, and most rheumatologists who are specialists in the case, they don't have a network or a channel with the primary care physicians or even the dermatologists who first see the lupus cases in skin lesions, or nephrologists who see lupus when it's gotten to a worser place like lupus nephritis. So health equity, looks like a place where patients have assistance in navigating and a say in what their care plan looks like.
And can you tell us a little bit about what the Lupus Research Alliance is doing to realize that vision?
Yeah, so the Lupus Research Alliance has two avenues or mechanisms that we're using. So one would be Lupus Therapeutics, which is an organization based on working in clinical trials in the lupus space. And what we do at Lupus Therapeutics is de-risk clinical trials. And we're expanding our idea of what a rheumatologist looks like. Rheumatology is not the most exciting field for people to get into. So there's large gaps between the patients and their providers. And so how we're addressing that is creating an avenue for up and incoming physicians to get into rheumatology. And that's being done by pushing our PIs to appoint or to mentor up and coming physicians so that they go into the place of rheumatology. Another aspect that we're doing at Lupus Therapeutics is that we are encouraging our coordinators to have a role in clinical trials at their site beyond just participating in the schedule of events or patient visits. We're having the nurses work with their PIs and their PIs work with their coordinators to understand that patients need to be asked. And I think what we've learned is that the coordinators have the best input of which patients would be recommended for a clinical trial. So we're asking and we are encouraging our coordinators to take a more present role in clinical trials at the site. And then on the Lupus Research Alliance side, we are working on a project, and it's called the Change Project. And what we're doing there is that we're spending a lot of time and efforts to expand health diversity, health equity, and trainings and education for both people with lupus and for the providers in the space.
Great. Thank you so much. So Kareem and Curtis, I'd love to ask you the same question of what health equity looks like and how you're working to realize that vision for your communities.
Thanks so much, Patty. I'll start and then kick it off to Curtis. Really excited. Health equity looks like actually the partnership that we have here today. I'm actually a community health scientist and a health disparities researcher, and the fact that I'm here with one of my community partners, Kurt Eskridge, a barber and owner of Cut It Out Kurt's, is exactly what health equity looks like to me. Particularly what we know, unfortunately, in the post and as we enter into an era, as we're hopefully moving beyond the pandemic, we unfortunately know that cancer screenings will be decreased for a large number of our patient population. Some studies are showing that up to 75 to almost 90% of cancer screenings have been decreased as a result of the pandemic. So as a result of that, health equity will look like making sure that despite someone's insurance, despite their zip code, despite where they live, and despite whether they are near a cancer center or not, they should be able to get the screenings that are recommended for them based on their age, family history, and risk factor. So health equity in that space looks like, to me, it looks like us going to the community. It looks like us embedding community-based screening education programs in the community so that the patients don't have to deal with the barriers and obstacles that they often have to deal with in order to get to us to get the screenings that they need.
Thank you. Curtis?
So I've noticed when I talk to my clients that they have a worry about price and how much something is going to cost. They really don't need to have to worry about how much stuff is going to cost. You need to worry about taking care of yourself and your family. So partnering with any and every organization that we can get to let them know that that is not going to be a problem, so they don't have that burden. And that helps out tremendously when you don't have to worry about how much something is going to cost. That is the biggest issue in our community, knowing how much something is going to cost. That always bothers us. And when it comes to taking care of ourselves or our family or anything, it's a problem that needs to be alleviated as soon as possible so we can help people take care of themselves a lot better.
Yeah. Thank you, Curtis. Melody, would love to hear from you.
Sure. So I believe that health equity for us would mean being qualified and recognized in the disease space. Having been a person that it took over 20 years to actually get to proper diagnosis, that is a resounding story in our community, that it takes years and years and years, and they're often not factored in to the disease space of IBD. So they don't get diagnosed with Crohn's or ulcerative colitis because they don't represent what this community has conveyed for a long time. Although Black and Brown people have been diagnosed for years, over 50 years, but the representation of this has not included us.
And can you tell us a little bit about what your organization is doing to push towards that vision?
Absolutely. We do programs to educate and help bring our community members to baseline and understanding the disease. A lot of time, the inequity, after taking so long for them to be diagnosed, the inequity starts with what they're provided, and they're usually provided with nothing. And then when they are provided with things, they're usually pamphlets or some reading material that does not speak to who they are or in a language that's easily comprehensive. So we provide programs through Methamedic, which we allow doctors to get in front of patients to kind of remove the lens of inferiority and superiority. We've done research on our community so that they're now being factored in as a viable patient group. And we have created the first Equity in IBD Patient Symposium, where it's a full circle approach to providing them information on what the disease is, how this affects Black and Brown people, because our disease is usually moderate to severe, and even advocacy and clinical trials information. So we're taking this opportunity with this conference to really get us to a space where we can start to reach baseline.
Thank you, Melody. And Francine, can you offer us your perspective?
Sure, thank you. So, for many Native American populations, we do have our own healthcare system. Unfortunately, because of generational trauma and the experiences that we've had as Native Americans, many times there's a hesitancy to get proper care. And what we're trying to do moving forward, primarily with cancer patients, is they are diagnosed a little bit later in their stages. And the reason for that is because there's not proper screening done sooner rather than later. And so we're hoping that we'll be able to work with our local Indian Health Service to improve the education of why screenings are important, but also when someone is diagnosed, it could be cancer, it could be diabetes, it could be someone who, just found out they're pregnant. There is not that mental behavioral referral for individuals to talk about what they're going through, their feelings, their emotions when they're diagnosed with something. And so, that's a health disparity that adds to, what people are already going through. The inequality of care, an integrated healthcare system is really what we need. And so working with our community members to understand their needs and their concerns through focus groups, through one-on-one interviews, is going to help us be able to advocate for them to have better guidelines, better procedures when they are going to our healthcare system. And so a lot of the research projects that we do with Johns Hopkins and the White Mountain Apache Tribe focus on the concerns of our tribal members and our tribal leaders to address the health disparities within our community.
I think that's something that we've all been brought to over the last year, is that we do need an integrated care model which addresses behavioral health, mental health, as well as the other disease states that patients are experiencing. This is so important, such a core part. I think we've heard loud and clear from communities that this combined package is really what is needed in order to help them to better address their disease and not just think about the particular condition, but also their broader behavioral health, mental health, especially with the year that we have years we've all been through already. So thank you for that. So I'd like to get a little bit deeper into the interventions and the specifics of the programs that all of you are running in partnership with your community. So Kareem, could we start with you? For the University of Illinois Cancer Center's UICAN project, the partnership obviously with Curtis, and having made a site visit, some of the salons as well. These are such powerful partnerships. And I just wonder if you can tell us how these particular partnerships came about and how you'll be using them, not only in the cancer space, but also beyond.
Thank you so much, Patty. Yeah, I'm very fortunate to do a type of research. It's called community-based participatory research, CBPR. And in that model of CBPR, the partnership is at the center of that model. And not only partnership, but equitable partnership. So creating spaces and places where the community partner and the academic partner sit in an equitable way to help think about what the intervention will look like from a design and implementation perspective. So I've been working with an organization called Project Brotherhood for almost 10 years now. And in working with Project Brotherhood, I started off as a volunteer and learning what they did on the south side of Chicago for almost 25 years now. They used to run a clinic on the south side of Chicago that was a holistic one-stop shop for African American men's health. Black men could stop into Project Brotherhood and located on the south side of Chicago, and they could get counseling, they could get support, they could get job readiness training, resume support, all in addition to providing quality primary care. And in addition to that, Project Brotherhood also had a partnership of barbers. And Kurt happened to be one of those barbers that affiliated and partnered with Project Brotherhood. So when our community partners said we wanted to address the elevated rates of colorectal cancer's death and mortality on the south side of Chicago, we thought what better way than to leverage the capacity and the partnership that our community partner had with the barbers like Kurt, as well as beauticians that were around the corner. So we created this community hub model where we had within that was linked. Our community health center, our FQHC, serves as the epicenter of that community hub model. But then we have a barbershop and a beauty salon, and also in that community area, along with faith partnerships. There's also a church and a faith center in that community area, all in the same zip code. Because our hope is that if we can create a place where someone can go into the barbershop, Kurt, or the beauty salon, and they can get educated about colorectal cancer screening, and then they can actually be given a stool-based kit to take home to get screened, and then they can be referred to the community clinic that's within walking distance of the barbershop. We're hoping that that type of community hub model will address a lot of the barriers in terms of access that many of our patients deal with and face.
Yeah, that's always the question, right? I get screened, and then what? Will there be
Yeah.
somebody to help me once I get diagnosed to get the care I need? It's so
And then
critical.
also,
Thank you.
Patty, the other piece of that is that the Project Brotherhood model is that when men walked into the clinic, they saw men that had a similar lived experience as they did. Now we understand, and this was talked about earlier by Susan, this concept of cultural congruency when it comes to not just addressing health equity in terms of access for our patients, but also thinking about health equity in terms of training the next generation. So I was able to start working with Project Brotherhood as a graduate student, as a volunteer, and to really learn what true community partnerships look like. So now as a researcher, that trust is already built, and I feel like I was trained both by the community as well as in formal academia.
That's right. And you've stayed there, right? You're known, you've stayed in place. It's been a sustained partnership. And it's so powerful that this cancer center, with all of its expertise, is being brought together with the community partners who have such strong connections to the communities and have such trust there. So Curtis, can you tell us about the role that you and your barbershop play in the colorectal screening program, and how you've become over the years such a trusted voice and source for health information for your customers and your community?
Yes. Thank you for asking me, and thank you for having me. So, what we do here at the barbershop first is, I think God brings customers in, of course, and then we do a good job of keeping them in by taking care of them and their hair, and we build relationships. So, after building a relationship with an individual or a family, what happens is they constantly keep coming, and that's our job, to keep them coming in over a period of time. And I've actually developed such good relationships with people. I've cut three generations of families. So, when you can cut that many heads or that many generations, you can impact them in a lot of different ways. So they trust us to keep coming. They trust our opinions, and they trust us to give them good information, because they can see me and see other individuals like themselves, and they have questions. So the questions that they might have, and they let their guards down. So the questions they might have will help them in so many ways because they're seeing us every week or every 2 weeks or once a month. And over a period of time, they know that they're getting the truth. They know that we're going to tell it like it is and tell them what they should do and what they shouldn't do in terms of health, in terms of relationships, and a lot of other things. And when you build those relationships and you build them over a period of time, they're going to trust you with a lot of part of their life. And then they can see the result in me and my other barbers and how we're living our lives and trust us even more. And it's a great idea. And it should be over the, not just Chicago, the South Side, but the United States and the world, because everybody, black and brown, and you have to come get your hair cut sooner or later if you want to look a certain kind of way. So that really helps us get the people. And if you're going to look right, you need to come see us and not do it yourself. Okay, remember that, everybody. Come to some kind of shop, get some trust, and build a relationship with your beautician or barber so you guys can form a lifetime partnership. It's a great thing.
Yeah, it was great to see when I visited you and also the salons there. And even as you just said, your shop is a place where life information is transferred and shared on all different kinds of topics, and health is just in there as well. So just wonderful that this has been such a powerful partnership and will continue to be going forward. So thank you. So Francine, I'd love to hear more from you about how Hopkins and the White Mountain Apache Tribe work together and how you've created community advisory boards and those focus groups that you mentioned. Can you tell us a little bit about how those are created, what the process is, how you gather people to participate in those, and then how you use the information as well to inform your interventions?
Sure. So I'm not sure if many people are aware, but Johns Hopkins and the White Mountain Apache Tribe have had a 42-year relationship. And so that partnership has evolved over, many years. And the majority of our staff are from the community, born and raised tribal members who work on health research with us. And so as far as our advisory boards, go, when we're getting ready to start a new project or even do a proposal, we will identify different community members, different agencies within the tribe, the Indian Health Service, partners we've worked with for a long time, and ask, for individuals to sit on an advisory board. And this advisory board will go over the study protocol, interview questions, if we're going to have interview questions. They will go over the curriculum with us. We also have our staff go over the curriculum because we want it to be culturally appropriate, but also effective in the manner that we're going to deliver curriculum, surveys, assessments, so that people are able to feel supported when they're participating in our research, but also for us to explain to our advisory board members the importance of why we need to do the research, but also get their feedback on what elements might need to be added and what other things we need to consider when we're going to work with our community members who will, volunteer to participate in our research studies. The focus groups are primarily to understand from community members primarily, but also we need to understand from our healthcare providers and providers who are in departments, agencies where they provide specific services to our community members, so that we have a better understanding of what they see, because they have more contact maybe on a daily basis. Providers from the Indian Health Service will also share what their process is when someone is seen at the clinic, the emergency room, if somebody's admitted into the hospital. So for us to have that knowledge allows us to better understand how we're going to develop our programs, but also to be mindful when we're working with our community members and to take into account what we don't know and what they're going to teach us. And so, I'm sorry, I just drew a blank on his name, the first presenter. He explained that he learned academia, but also learned from the community members when he was a graduate student. And that's the same for us. Our community members are going to teach us what we need to know in order to help them and our community members through their health issues, through their emotional issues, the mental health. Just being able to make that connection one-on-one with someone allows you to establish a relationship and understand their needs, help them through it, but also being a support system for them, but not doing everything for them. I hope that makes sense. And the focus groups and advisory boards is the formative research that we do so that we have an understanding prior to us starting a new project or even thinking about submitting a grant proposal.
Yeah. So you get their advice on the front end. Do you also interact with them during the implementation of the project so you can let them know how it's going, present any challenges to them? So do they end up being a resource throughout the project or just so much at the beginning?
Yes, so the Community Advisory Board will have so many meetings prior to a research project starting, but then we usually have either quarterly or community advisory boards every couple of months, every few months. So it's important to keep them involved because, especially for curriculum, if we're working on a curriculum and one of our participants indicates that they don't understand something or it's not flowing based on the feedback from our staff, then we'll also, update the community advisory board that this isn't working. Do they have any thoughts? But we're also going to get feedback from our staff and our program supervisors, coordinators, and managers so that we can make any adaptations or adjustments necessary so that the curriculum, how it's being delivered, will flow more smoothly.
Great, thank you. So Susan, I'd like to ask you a little bit about clinical trial diversity. We know this is so important, and I wonder if you could share some of the Alliance's efforts to increase diversity in clinical trials and also just making clinical trials a regular part of high quality healthcare.
Sure, thank you, Patty. So I would like to I would like to get into that, but I would like to start off by just highlighting what the common theme across all of our spaces of what health equity looks like, and it's time. A lot of the consistency across is that the delay between being diagnosed and treatment is unique and is a big factor in determining the quality of care that we are receiving as people of color. So one of the key roles at Lupus Therapeutics when we're partnering with pharmaceutical companies and is to minimize the time it takes for sites to get up and open for activation to enroll patients, and then also minimize the time it takes for patients to be diagnosed. So the ways that we're doing this, as I mentioned before, was changing or teaching our PIs to take a different approach to clinical trials, but also the coordinators. So historically, clinical trials is a powerhouse, or the responsibility of clinical trials still remains highly on the PI. But as we know in healthcare, the PIs do have the PIs are usually your doctor, your primary care physicians, or your specialists, and then your coordinators are usually your nurses or support staff. The patients have more interaction with the coordinators on a day-to-day basis. So what we're trying to do is use that as an avenue, and not as a weakness or a breakdown, but as an avenue to try and decrease the amount of time that a patient is recognized to be asked to participate in a clinical trial, and for a patient to be treated or introduced to this investigational option as a good quality of care. So one of the things that is very important to us at the Lupus Research Alliance and Lupus Therapeutics is making sure that our PIs, our coordinators, and our patient and subject network are fully educated. So we run a series of educational I want to say seminars or interactions with both the PIs. We have a network of organizations that we work with, where we focus on clinical trials education for patients and their families, coordinators, educators, and we do that with the Minority Equity Forum. And then we also have a partnership with the National Kidney Foundation, because we're focusing on making sure we're closing those gaps that are creating these lapse in times where people are not getting treatment or don't know what their treatment options are. Now, when we talk about how do we make clinical trials a space for quality care, it's part of changing the behaviors around clinical trials, right? In this country, we have a poor history of clinical trials, especially in the space of colored people. And what we need to do, and what we have been doing, is changing what that looks like, changing what that story is. And that's not erasing the history, but understanding it, acknowledging it, and changing what the history would look like in a few years by creating a different environment. So what we push education for our PIs, we push education for our coordinators, and then we also push education for our patients and the broader community. These are support family members, even people in the church. We have we've worked with Black Nurses Rock. A lot of efforts have been made in the community to teach about clinical trials. And then apart from that, internally, what we do at Lupus Therapeutics is when we partner with our pharmaceutical partners, we ask them to include the patients in the beginning of assessment. Like if they're deciding that they're going to go with a particular asset, we do include our we have a patient protocol review committee, and we ask them to utilize the patient's input so that when they are designing a clinical trial, that this clinical trial is appropriate for the patients that they are looking to have participate in the trial. What we've learned and what we see is that although lupus itself as a disease disproportionately affects people of color, specifically Black women of Afro descent, we don't have those numbers in our clinical trials. Our clinical trials are not reflective of the population that is harmed by lupus. So changing that means changing the behaviors of the PIs, the coordinators, and also the look or the understanding of what clinical trials is, and changing how we conduct clinical trials. Clinical trials, we're moving away from the space of, where we want to know what this drug does, and we're moving into a space of we want to know how this drug works for you, right? And how we do that is making sure that we get the patient embedded from protocol design all the way through protocol journey. And then when we get into the protocol journey, we have support systems around patients that are in the clinical trials. And we have a program, a PALS program, and they're patients, people who have lupus that have both been in clinical trials, have not been in clinical trials, and they are all a part of the mapping the journey. And this is a ongoing cycle. So the goal is that once there is an asset, a pharmaceutical company is interested in exploring an asset, that they would meet. We have a scientific review committee that they would meet with, and that would be a board of our PIs. And these PIs are being trained with the behavioral change, right? And then once that asset has been agreed to, like this is the best asset for lupus at this time, once it goes into the protocol development stage, that they start touching base with patients and getting their buy-in on what endpoints are good for both the patient and the pharmaceutical company, and then what the assessments and visits look like, what the patient burden looks like. And once we start incorporating those changes into the protocol, we find that we have a protocol that is better fitted for the community that it needs to serve versus a protocol that only a select few can participate in and get that option of care, right? We are working in the community to really educate about clinical trials so that we have people understand that it's not, there's a danger around clinical trials for people of color. And we're trying to change that so that they can understand that clinical trials is actually and can be an avenue for a quality of care, an option, an investigational option that they have a right to. And but we first have to make sure that they understand it's a safe space. So those are the main areas that we're addressing to make sure that we can make that change and include clinical trials as a high quality, as part of a high quality care for our patients and people living with lupus.
Yeah. Thank you so much, Susan. I think you've really driven home that it has to be an integrated package of interventions, that just doing one piece of informing the community is not enough. Even with your great PALS program, to have a patient who's been through a trial to sort of support a patient going through, that's not enough. That the coordinators are so key, the investigators have to be trained, that it's really a whole package of interventions together that need to be aligned to really make a difference rather than just taking on one piece. So thank you for giving us that overview. And so Melody, can you share with us how the Color of Crohn's and chronic illnesses approach to engaging and supporting Black, Indigenous, and people of color who are affected by IBD and digestive disorders?
Absolutely. We have a group of ambassadors, and we started that program because we continued to have people that wanted to be a part of the community, but in a bigger way. So we created our ambassador program, and it's very diverse. We have men, women, Black, brown, Asian. And what they do is they actually go out and look for other people of color. And it gives a lot of confidence to the person when they come to our group, because they're not just being like, you can be on social media and people will just follow you and they'll keep liking your pictures, but there's no real engagement. Our ambassadors will go and communicate with people, answer their questions. And there's often a lot of hesitancy with community of color. So it could be like with clinical trials, we find hesitancy there, or just an adverse response to it. And we're trying to kind of remove those blocks or barriers for a point of entry. I recall having someone tell me that they weren't ready to participate or learn more until they did their own research, because people have taken advantage of them and used their name to exploit them. I wasn't sure what they meant, but I acknowledged that I understood, because people need to be seen and they need to be heard. But I understood what they were trying to convey to me, not necessarily that I was trying to use them or take something from them, but there's the layer of what are they going to do to me? Why are they trying to connect with me? What do they really want from me that we face in this community? And when we're facing that, the ambassadors, we've trained them and taught them how to tell their story, but to make them feel more confident too in engaging and knowing that their story actually will bring help and healing and opportunity to others to get to that same space. So we really have a grassroots kind of approach to how we find community members. We're at over 500 community members now, and we're constantly growing. But authenticity and genuine approaches are very important. And sometimes for me, initially, I think we were at about 250, and I had engaged with almost every single person, sharing their story, my story, answering their questions, and that removed their fear or the thought that she's coming in to take advantage. And then once they actually got into coaching, they saw the support group and Meet the Medic, and that there were more people that had similar stories and they weren't an anomaly, it gave them some kind of validation and solace. And we started seeing more and more people share their stories. And that's important in our community, because we carry a layer of fear that makes us feel like, if I go into this space, how is it negatively going to impact me? Because we see the negativity so much more than we can see the opportunity, because of what's happened to us historically. And that is a part of the structural racism.
Thank you so much for that. I love how you talked about, the fear in terms of what do they want from me? And I think that comes about from sort of parachuting in and out, right? I think a theme in this discussion has been the staying power of partnerships, being there.
Yes.
And also being prepared to not see resistance. But what you're seeing is, it sounds like what you're telling us is that people have legitimate questions. They have
Yes.
a need for information, and they need it to come from a trusted source. And that if you just respond to that, you can probably get in a totally different place, both in terms of folks accessing the care that they need, but also participating in research, et cetera.
But their hesitation is also very valid. When we look at
Of
things
course.
historically, and I make sure that our community members and our ambassadors know that just because someone has hesitation, it doesn't mean that they're rejecting you. The hesitation is a very solid foundation for them, because what the world and health has presented to them. We don't know what trauma they've endured, and we don't know how they're feeling emotionally or mentally, especially with IBD and the lack of resources for Black and Brown people. They don't know what this is, because we're newer in this space, a couple of years old. So they may not have heard of us. They don't know if this is a scam because of social media and how these things are targeting people that seem more likely to say yes. And that may have happened for something else, not necessarily a person in the health space or someone presenting an opportunity. So the rejection, the hesitancy is not a rejection of you as the person. They just don't know, and give them the space to understand and to vet out the viability.
Yeah, great. Thank you so much. Well, thank you to all of you for mostly the work that you do, the incredible work. You're showing us the way. Really, the purpose of this panel was to share with the broader community that there are solutions, there are models that are effective for engaging communities in partnership and actually moving the needle on the inequities that exist, with a perspective of what is valuable to the community, what is valuable to the patient, and really having that be the main driver in our North Star as we look to address health disparities and health inequities. So thank you so much. Some big takeaways for me. I mean, as always, trust is such an important aspect of the quality of relationships. So folks can have partnerships, but really thinking about what ends up with those being high quality relationships. The staying power, sustained relationships over time seems extremely important from what we've shared. Connecting with folks in the community when other needs that they have are also being addressed. And when they're seeking other services, including going to Kurt's barbershop to get a haircut, can also be a chance to get some health information as well. And then I think really, as all of you have said, it's not just one intervention, it's really a combination of interventions that run the continuum from how do we design a response or a program with the community's input and continuously update them, but then also engage the community as partners in delivering it and partnering with it as well. It was really interesting to hear Susan talk about, and as well as Kareem, almost a new kind of clinical trial team, a research team that also involves community scientists, that involves people from the community working alongside coordinators and PIs as well, that this inclusive approach, this team approach to clinical trials and research of all kinds to address health inequities can be a really important way to go forward. So many thanks to all of you for your work and for being with us here today. And on behalf of Bristol Myers Squibb, we want to thank all of you who have joined us, and we hope you'll take these lessons and these models forward in your work as well. We can't do this alone. We all have to work together, and I think our panel has made it clear just how important that is to communities as well. So thank you all, and enjoy the rest of the conference.
Thank you so much for joining this breakout session. We'll see you all back here at 11 a.m. for a conversation between the United States Secretary of Health and Human Services, Javier Becerra, and Atlantic Senior Editor Van Newkirk II.